Okay, this very technologically important machine now works. So it gives me pleasure to start our third session today. We're moving on to sort of host tissue responses, and we've got two speakers this afternoon. The first speaker actually needs no introduction whatsoever. I was very tempted to introduce him as the third man, because we've actually heard from Professor Fahal and we've heard from Professor Magoob, but I think maybe you're the first man, so let me introduce you as the first man. And the title of the lecture, of course, is on the board, so let's get cracking with what you've got to tell us.
Well, thank you very much, and thank you for promoting me. My talk will be the pathology of mycetoma in Sudan. I will be talking mainly on the tissue responses, but at the same time, I will say a few words about, the morphology of the grains. Now, the main agents, and this is a repetition, I suppose, causing mycetoma in Sudan are Mmycetoma, and the commonest cause is Mycetomatis, then Actinomycetoma, Streptomyces somaliensis is the commonest in this group, Actinomadura maduri and Actinomadura pelletieri, they are less common. Now, the objective of this presentation, or the objectives, are to describe and discuss the pathology and immunopathology of the two of the commonest causes of mycetoma in Sudan, Mycetomatis and somaliensis. The structure, I'm going also to discuss the structure of the causative agents, and as we see it under the microscope, and the host inflammatory response at the light microscopic and ultrastructural levels, and I will also be discussing the immunological events that we detect in the lesion. Now, until recently, why we are doing this, until recently, this was some years ago, very little was known about the detailed pathology, pathogenesis, and immunology of mycetoma. An understanding of these processes and a proper characterization of the host mycetoma agent interaction may explain the chronicity of mycetoma and may also help in the development of better therapeutic and preventive interventions. This is, the mycetoma, swelling and so on. And this is, I thought was a nice picture, to look at, because it shows a sinus. The epidermis is up here, and that's the dermis. And as you can see, there are these grains. They are queuing, to exit, the underlying tissue. And the fate of these, we don't know what happens to them. Here is Mycetomatis. This is a specimen that was in our museum. I deposited it there some years ago. And as you can see in this foot, all these black things are the grains. And as you can see, although there is some fibrosis, but the organism really spreads in the facial planes and between tendons and invades bone. This is, what you don't want to see. Now, if you look at the grains, there are two types of grains, what is known as the filamentous grain and the vesicular one. The one that you see here is the filamentous form of grain. You can see the hyphae very easily, and you can see them much better if you do PAS or silver stains. And furthermore, the hyphae are embedded in cement substance and contains the brown to black pigment of the fungus. And this is the vesicular type of grain. You can see the cement substance in the middle, really devoid of hyphae. Then you go to the periphery, you will find the hyphae with swollen ends forming vesicles, and that is why we call it a vesicular type of grain. Now, we don't know really, the difference biologically between these two grains. The pigment is really melanin or melanine-like substance. If you stain the grain with Mason Fontana that stains melanin, it shows positive reaction. All this black material that you see here in the center of the grain is melanin or melanin-like substance. And please note the hyphae here at the periphery, they are surrounded by this pigment. And here this is another, beautiful stain for melanin called Schmorl stain, and it stains the melanin a nice blue color. And again, you can see at the growing margin of the grain, the hyphae stain also a bluish color. So they are really closed in the melanin. What does that mean? We don't know. May have something to do with the pathogenicity of the organism. A very interesting observation that was made by one of our students, Anahid, who is in the other room. She did atomic absorption spectrophotometry, and she found several metals, zinc, copper, calcium, ferric ions in the grains and in the surrounding tissue. The copper, zinc, and calcium was found in concentrations of 4, 6, and 16-fold higher than in normal tissues, respectively. The concentration of these metals increased with the severity of the disease. Further studies are needed to determine the contribution of melanin and metals to the pathogenicity of the fungus. Anahid, she has an idea that perhaps these metals are preventing somehow the antibiotics from reaching, the fungus. I don't know whether, unless we do further, studies. Now, I will come now to the classification of the inflammatory reaction that we see. We see 3 types of reaction: type 1, type 2, and type 3. I must remind you that these reactions, usually type 1 and type 2, may be seen in different grains in the same lesion. So it is really largely a local process of a particular grain in the lesion. Type 3, which is an epithelioid granuloma, this is uncommon, but we sometimes see it. And this is type 1 reaction. You can see the grain in the middle with the cement substance and some pigment, and the hyphae are cut, in different planes, so you see them as vacuoles. And in the surrounding tissue, you can see some neutrophils clinging, to the surface of the grain. And here, this is a special stain, immunohistochemistry, staining for CD15. CD15 stains neutrophils, and as you can see, this layer, brown layer, outside the grain is CD15 positive, indicating that these are neutrophils as we saw them in the H&E section. And this is an alkaline phosphatase, stain there. And here is the inflammatory reaction around the grain of Madurella mycetomatis in type 1 reaction. I would like you to see here, Yeah. If we start, from the bottom, if I can find the arrow, it's not there. Here it is. You can see there is the grain. This zone here is the neutrophils. And here I stain this section for macrophages. And the macrophage marker is CD68. And as you can see, the neutrophil zone now is negative. The middle zone, the macrophages, is positive, indicating that this, in fact, is the layer of the macrophages. And the outside layer is negative, and I will show you what it contains with other immunostaining monoclonal antibodies. And here you can see sometimes in that macrophage area there are foamy macrophages. Now in the past we used to say this is of host origin, but this girl Anahid has shown that in fact this is lipid, and she can find the lipid in the fungus itself, even in culture. So the possibility that it's also elaborated by the fungus or by or still could be of host origin. And this is a class 2 or type 2 reaction. Macrophages, sometimes these macrophages fuse together to form multinucleated Gann cells, as you can see here, and the neutrophils now have disappeared and they are replaced by these multinucleated Gann cells. These multinucleated Gann cells, they do what? They phagocytose, fragments of the fungus or that has been acted on by the neutrophils. Also, they phagocytose neutrophils. As you can see, there are a couple of cells here. And they form Gann cells. Why? Because macrophages are too small to engulf these big fragments. Therefore, the macrophages will join forces. They form multinucleated Gann cells that can engulf the big structures. Look at this multinucleated Gann cell up there. And this is type 3 reaction. And as you can see, and you agree with me, here in the middle is an epithelioid granuloma. Here it is. That's the epithelioid granuloma with surrounding fibrous tissue. And here we can see remnants of the fungus. In other words, in these sites, the fungus itself has been almost completely destroyed. And what we are left behind is some pigment and some cement substance. And eventually these will disappear. And what you will be seeing are pure granulomas. You can't distinguish them from any other form of granuloma. The thing that pointed out this to me, that this is related to the mycetoma, is the presence of remnants of the fungus or the cement substance. Another interesting feature in Madurella mycetomatis is fibrosis, encapsulation, particularly after antifungal treatment. This is a feature of this fungus. And these arrows now point to the fibrosis around. In the middle, there are some Gann cells, and I suppose they contain, fragments of the fungus. Now, I come now to the electron microscopy. Now, what you see there is, cement substance, that, black material. And then here, if you look at this, these are hyphae. I would like you to notice the lines, that are seen within the hypha. And this is a peculiar thing that happens. It's called hypha within hypha growth. It produces this rather distinctive appearance of this, grain. And you wonder, what the neutrophils are doing. And this is what these neutrophils are doing under the electron microscopy. We see here, that's a neutrophil. These are the nuclei of the neutrophil. And you can see this is the fungus grain with the cement substance. And you see that, the neutrophil is closely adherent to the cement substance or to the part of the grain. And this is at a higher magnification. And again, you can see here the cement substance. This is the neutrophil. This is a shy, neutrophil just peeping in with this part of its nucleus. And here, what you see are the granules of the neutrophil. Now, please note that as the neutrophil adheres to the cement substance, the grains are aligned along this line. And this is typical of immunoadherence of neutrophils. And I will show you in a minute that in fact these are tied up by certain molecules or antibody and complement and so on. And then they discharge, of course, their granules very rich in enzymes, and they cause digestion and fragmentation of the grain. And as you can see here, what we have is really just fragments of the fungus, and all these are probably the granules of the neutrophils. So the neutrophil is really destroying the grain. Now I will come now to discuss the immunological changes, and we stand these grains for complement, for IgG, and for IgM. And as you can see, in the complement stains a brown color by this immunoperoxidase. This is CD3. We can see it on the surface of the grain and also around intact hyphae within the grain. It was shown by another Mahjoub, previously, that in fact, using chambers and so on, in experimental animals, that in fact there is, activation of complement, and there is migration of leukocytes, across membranes into the across a gradient of complement. Now, this is again, you see IgG coating fungal hyphae, again by immunoperoxidase. And therefore, what we see here is an immunological reaction that attracts neutrophils, causing destruction of the grains. Now, the question is, if this happens, why doesn't the grain or the mycetoma disappear totally? We don't know. And the other thing is, does mycetoma at all heal spontaneously? We don't have an answer for that. And as has been mentioned today, if we work at the field level to see these very early lesions, or we have a marker for previous infection, then we can say that spontaneous healing does occur. But as far as I see, and one would expect, I will not find, clearing of the lesion, because these are symptomatic patients with usually advanced disease. It's not the same as you get, perhaps in the field. This is, a lesion in the bone. And as you can see here, there is a grain in the center with pigment at the periphery. And something very interesting. The inflammatory reaction in the bone is not that much. It's not like what you see in the soft tissues. I don't know why, but this is, the case. And here we can see a small reactive bone at the periphery, and there is perhaps a sequestrum there. And this is, you see, the sequestrum. Usually these are small, dead bone fragments, like what you get in tuberculosis. If you look at tuberculosis of the spine, the sequestra are not prominent, they are small. So here we have, the same thing. And as Ahmed has mentioned, pathological fractures, in these lesions are very, very few. And if you take an X-ray, you just see a cavity, very clear, very well demarcated, which is typical of this, Now, Ahmed has talked about, the dilated veins that these patients, get. And what happens, as you can see here, there is hyperplasia of the muscle layer of the vein, and the lumen is very narrow. And perhaps this is the reason why, the blood does not flow normally in these veins, and therefore there is stasis. Mycetoma, as has been mentioned this morning, behaves, sometimes like a malignant tumor. It spreads locally by lymphatics and rarely through the bloodstream. And the opposite is the spread of Mycetomatis from a foot to the inguinal lymph node. This is the specimen that Professor Fahal has shown, and I cut God knows how many sections just to make sure there is no blood spread, and all I could see was just spread through the lymphatics, and the regional lymph nodes were enlarged. Professor Mahjoub and myself have previously published, on the spread of mycetoma, and we found that actinomycetoma is more likely to spread, through these various, channels than Mycetomatis. And the very interesting thing is, you sometimes get, as has been mentioned this morning, mycetoma in places like the brain or the spinal cord, and there is no, no overlying sinus or evidence of penetration. It's possible that in these patients, what happens is that the agent of mycetoma is spread through the bloodstream and eventually lodges at a distant site, causing the, without leaving a trace, behind. And this is the lymph nodes. These are the lymph nodes in the inguinal region from that patient, and as you can see, they contain, the masses of grains. I will now pass just to discuss the immunopathology of actinomycetoma caused by Streptomyces somaliensis. This is, the cross-section of a typical lobed, grain of somaliensis. It is a very hard grain because it has got, cement substance, and it fragments. And I think it fragments mainly because it is invaded again by a type 1 reaction and neutrophils that fragment, and its color is this nice lilac, appearance, very, easy to see. Now we know, of course, there are, different strains of this, and I don't know, whether they will cause different pathologies or not, but this is what you see. Again, this is a grain in the center. It's not taking, up the stain, and I stain this with CD15 again. This stains neutrophils, and as you can see, there is there are a lot of neutrophils around the grain, and again adherent to the surface of the grain. So this is a type 1 reaction in somaliensis. This is CD68. Remember, this stains the macrophages. And as you can see here, the neutrophils now, see the specificity. The grain is negative, the neutrophil zone is negative, and then in the second tier or layer of the middle layer of the reaction, the cells are positive for CD68, indicating that we are dealing here with macrophages. And again, this is CD68. All the brown stuff that you see there, these are Gann cells and macrophages immediately adjacent to the grain in type 2 reaction. The neutrophils of type 1 reaction have largely disappeared. Now, here we can see the staining of the section for CD3. CD3 stains T cells. It is a pan T cell, stain. And you can see it in the middle zone, in this case of somaliensis. In other words, it is mixed, if you like, with the macrophages. And here I stain this section for B lymphocytes. The stain, the monoclonal antibody is CD20, and you can see the lymphocytes mainly in the outermost zone around the grain. And here is IgM on the surface of the grain, and in filaments within the grain, neutrophils adhering to the surface of the grain in type 1 reaction. And this is IgG, is less than IgA positivity. I must say the same immunoglobulins are found in Mycetomatis. And here, complement 3 on the filaments inside the grain. Cells in the innermost part of the neutrophil zone also are positive, and this is where the neutrophils will adhere. I must say, the fragmentation of this, somaliensis is not as much as in Mycetomatis, perhaps because the cement substance is more tough in somaliensis. Then I ask myself, what type of reaction is there in the somaliensis? And I stained, for type 1 cytokines and type 2. So I stained IL-4 and for IL-10 in the section. And as you can see, all the brown stuff, these are positive for IL-4. Interferon gamma was absent, and there was also IL-10 in the follicles, IL-4 in the paracortex of regional lymph nodes, indicating that these T cells are responding by a Th2 type of cytokines. IL-10 was mainly in the follicles of the lymph nodes and cells lining the sinusoids. There were few interferon gamma in the paracortex. So in conclusion, the cellular reaction around the grains of Mycetomatis and somaliensis is arranged in 3 zones. From within out, these are neutrophils, macrophages, lymphocytes, and plasma cells. Type 1 reaction consists of all 3 zones. Type 2 consists of macrophages, lymphocytes, and plasma cells. Immunoglobulins and complement are found on the surface of grains and on the intact filaments within the grains. Neutrophils are attached to grains by complement fractions, and neutrophils destroy the grain probably by ADCC reaction. And the cytokines response in the lesions and draining lymph nodes is predominantly a type 2-like response. And here, this is, from the garden of the Institute of Endemic Diseases in Doka Research Station in Gadaref State. I took this photograph in March, this year, and I present this to my colleagues, Mahjoub and Fahal. I know that this is only a digital buffet, or not buffet, what do you call it, bouquet. So please accept it. And no copyright. You can do what you like with it. Thank you very much. Yeah? Yes, I will.
Yes. Can I thank you? This one works. And I thank you for that very elegant talk. I think we're going to take questions at the end of the session, if that's okay. But I'd like also to commend you for saying several times that there's things that we don't know. I think this is very refreshing to hear in a lecture. Thank you very much. So we move on now on a similar theme that was introduced earlier in the day by one or two speakers, and Wendy's going to take this further, and she's going to talk about host factors that predispose towards mycetoma development. A very interesting and I think a very important area.
Thank you again for the introduction. I will tell you something more about host factors involved in mycetoma. I start with a simple observation. It has been established that mycetoma causative agents reside in the soil, and people in the endemic areas tend to walk barefoot on the soil. So therefore, probably everybody in the endemic area walking barefoot is exposed to these microorganisms. We showed this earlier as well when we found some antigens of Mycetomatis in our lab. We screened sera from both patients and healthy controls. We actually found that both patient and healthy controls had antibody responses against Mycetomatis. So the question arose, why do some people develop mycetoma and others not? Another observation we made is that mycetoma is more common in males than in females. And this is actually found all over the world. For instance, here in Bengal, you can see that about 1/3 of the cases is in a woman, while 2/3 is in a man. In Senegal, the difference is even bigger, so there are less women infected with mycetoma. And here in Sudan, the ratio is about 1:5. Male predominance is not only found in Mmycetoma, but also in other fungal infections of the subcutaneous tissue. These include paracoccidiomycosis, coccidiomycosis, and chromoblastomycosis. But for these infections, some research has already done to the role of sex hormones in the development of these mycoses. And they found that estrogen actually offers protection against the infection. For instance, in the case of paracoccidiomycosis, you have conidia and hyphae, which are not found in the infection. The infectious state of this fungus is the yeast form, and estrogen actually inhibits the transition from conidia to yeast form. So it delays it. This gives the immune system a longer time to react against paracoccidiomycosis. But actually nothing was known about mycetoma. So we decided to do a SNP analysis. And for those of you who are not familiar with SNPs, SNPs are single nucleotide polymorphisms, which simply means that there's a substitution of a single amino acid. For instance, this part of the sequence, this is the part, for instance, you inherited from your mother, and this is the part you inherited from your father. So in this case, there's a heterozygote with two differences. So in this part of the genome you have an A, and in this part a T. Single nucleotide polymorphisms can result in no change in enzyme activity. That's, for instance, if the substitution didn't result in a difference in amino acid. So if there's no difference in amino acid, the enzyme is still unchanged. It could also result in a higher enzyme activity in case the substitution is beneficial for the enzyme, or in a lower enzyme activity. For instance, if the substitution was at this part of the enzyme, this interferes with the binding site of the substrate to the enzyme. We did a SNP analysis on genes involved in hormone synthesis, and we took 125 patients and 103 healthy matched controls, all from the endemic area here in Sudan. This is a scheme about the sex hormone synthesis in our own body, in the human situation. It starts with cholesterol, which is transferred into pregnenolone and then on to progesterone, DHA, estradiol, and testosterone. All these genes you see are, for instance, CYP17 and CYP19. Polymorphisms have been described. I only choose those polymorphisms which were already known to influence enzyme activity. I performed an RFLP analysis, which means that you amplify the target gene and use a restriction endonucleases to see if there's a transition in amino acid, in nucleotides. So if you see it in the laboratory, it looks like this. I have three genotypes on this gel. A homozygote for the AA allele, which means that both the parental and the maternal gene had an A amino acid. A homozygote is for the GG allele, so both genes had a G allele. And of course, if your mother and your father had a different variant of the gene, you'll be heterozygotes, and in this case you get an AG genotype. For CYP19, the AA genotype was only one band, so the restriction enzyme didn't cut this band. The GG genotype, then in both strands the enzyme cut, so you have two small bands, and in the heterozygotes case you have three bands. And you do this for all your patient and healthy controls, and you just look at the gel to see the results. In the case of CYP19, we found this distribution. So 80 of our patients had the AA genotype, 37 had the AG genotype, and 8 had the GG genotype. This differs in the controls, because in the controls we had relatively more G alleles than in the patients. Interestingly, this was in the patients we had a more active variant of this gene. CYP19 encodes the transversion from testosterone to estradiol. Another difference we found was in the COM gene. This gene transfers 4-hydroxyestradiol into 4-methoxyestradiol. And again we did the same analysis. And again in the patient population we find a high activity variant of this enzyme. Interestingly, the COM gene was also associated with lesion size. So we found in the massive lesions the higher activity more often. So when we summarize, I did multiple SNPs, but only 2 SNPs were significant. Those were the CYP19 gene and the COM gene. And CYP19 in the patient population was associated with a higher rate of transversion from testosterone to estradiol. And the COM gene was also associated at the higher transversion rate. So theoretically, in our patient population, we should have a higher concentration of estradiol. But this higher concentration of estradiol is also degraded faster into 4-methoxyestradiol. So we wondered what the phenotype would be. We therefore measured beta estradiol concentration in both patients and healthy controls. But of course you cannot do this by including both males and females in the same pile. So I split the data into male patients versus male controls and in female patients versus female controls. And as you can see here, we indeed find a higher concentration of beta estradiol in our male patients compared to our male controls. We didn't find this for the female population. One of the reasons why we didn't find this is that you can see that there's lots of variation in the female side. That's probably because we didn't take one day on the menstrual cycle. So all the different days are present in this population. And the estradiol concentration, of course, varies with the menstrual cycle. So if you did find a higher level of estradiol in a patient, should these patients have lower levels of testosterone? Because of course we found the difference in the CYP19 gene, which converts the testosterone into estradiol. So we measured testosterone, and surprisingly we didn't find any difference. So the male patients versus the male control were identical, and the female patients and the female controls were identical too. So there were no significant differences in testosterone concentrations. So if the higher estradiol concentration was not related to a lower testosterone concentration, what of the other hormones was then of influence? Well, if you look at this scheme, the easiest way was testosterone into estradiol, but estradiol can also be formed by transversion of DHEA into androstenedione, into estrone, and then into estradiol. So we measured DHEA, and we found the following. Indeed, we found lower concentrations of this hormone in male patients versus male controls. We did find the same in our female population. So in summarizing, we find higher estradiol levels in males, we found lower DHEA levels in females, and we didn't find any difference in testosterone levels. So we then wondered, could this difference in hormone level have a direct effect on the fungus? In the past, some people already studied this by measuring the colony diameter. And in these studies they found that progesterone was inhibitory on Mycetomatis growth. But in the case of Mycetomatis in our lab, we noticed that even with the same strain, the colony diameter can vary. We therefore decided to use another approach. In our lab, we developed in the past antifungal susceptibility assays, in which we had to standardize the inoculum. We do this by growing the fungus in a liquid culture when you get a little fungal ball. If you then fragment the fungus by sonication, you get little hyphal fragments. By standardizing the inoculum to a transmission level of 70%, you get a very highly standardized solution. I repeated this in our lab about 100 times and always get the same results. So I made this standardized solution and did it in following tubes. Then I did a viability staining, and I did this with the tetrazolium salt XCT. XCT is transferred into a colored product by mitochondrial dehydrogenases. So if the fungus is growing, you get an orange color. So by measuring it in time, you get the following results. So when you start, the fungus is not growing very good, it has a lag phase, so little XCT is transformed into formazon. After a while, the transformation rate becomes better and you get a higher color. So we did this for 12 days and we got the following growth curve. The black line are the controls with no hormone added. And you can see after 3 days it grows. In the first 3 days there's a very high growth rate, and later on it remains rather stable. But when we added the hormone levels at 10 times the serum concentrations described, all the lines were on the same place. So there was no statistical difference between adding a growth sex hormone or adding no hormone at all. Only when we added about 100 to 1,000 times the serum concentration of progesterone and DHEA, we did find some inhibition of these sex hormones to the growth of Mycetomatis. So in conclusion, we found some genetic differences observed between patients and healthy controls in the CYP19 and the COM gene, the genotype related with higher 17-beta estradiol levels, which was also demonstrated phenotypically, low DHA levels were present, and sex hormones had no direct influence on Mycetomatis growth. So what could be this role of sex hormones in mycetoma? Well, actually, sex hormones also influence the inflammatory response towards pathogens and non-pathogens. It has some anti-inflammatory roles, is the inflammation reaction is an inflammation without an infectious agent present. Interestingly, it has pro-inflammatory effects if it's an inflammation with an infectious agent. And of course, in the case of mycetoma, there's an infectious agent present. So we saw in the previous presentation some nice pictures of the inflammation in mycetoma. So this picture should look familiar. This is a type 1 reaction in which you find the grain surrounded by a large zone of neutrophils. Since this large zone of neutrophils is often present, I focused on the neutrophil. And this is a scheme about how the immune response, the innate immune response, is supposed to happen when a fungus enters the human body. When the fungus enters the human body, mannose-binding lectin and complement 3 are supposed to be deposited on the fungus. By doing so, macrophages already present in healthy skin are able to recognize the fungus. If a macrophage recognizes the fungus, it will start to secrete some cytokines and chemokines to attract monocytes and neutrophils to the site of infection. In order to attract monocytes, macrophage MCP is secreted, and these monocytes then come from the bloodstream into the tissue and develop into macrophages. In order to attract neutrophils to the site of infection, interleukin 8 is secreted, and interleukin 8 is recognized by the receptor CXCR2 on neutrophils. When the neutrophils are present, they will try to destroy the fungus by the secretion of oxygen and nitrogen radicals by the gene nitric oxide synthesis 2. So by using this scheme, again we took 125 patients and 140 healthy controls, and we did again a SNP analysis. We selected some genes of interest which were involved in this innate immune response. And we used complement receptor 1, interleukin 8 and the receptor for interleukin 8, mannose-binding lectin, MCP1, nitric oxide synthesis 2, TNF-alpha and thrombosponin 4. And again we performed the SNP analysis. So this picture should look familiar by now. We did find some differences in the NOS2 Lamborghini gene. So when we summarize our SNP analysis based on these genes, we actually found the following. We found quite some genes which were differently between patients and healthy controls. We found genetically different